So it's 2 a.m., you're in the emergency department, it's chaotic, the monitors are all beeping, and a patient has just been rolled into the resus bay. They look sick. I mean, really sick.
Yeah.
And the lab tech runs in and shouts the first critical value. Lactate is 8.0.
That is the pucker factor moment, as they say.
Huge alarm bells, right. I mean, normal is under 2. And 8.0, that triggers an almost Pavlovian response in any clinician.
Oh, absolutely. The brain just screams sepsis or hypoxia. The cells are suffocating.
And the immediate reaction is, fluids, antibiotics, pressors, fix the flow problem.
But that's the twist.
Yeah.
And it's really the whole reason we're doing this deep dive, that 8.0. It's a signal. It's not the diagnosis itself. And if you automatically assume it's a lack of oxygen, you could. Well, you could actually do more harm than good.
That's a pretty terrifying thought.
It is. So today we're going to unpack this, drawing from a stack of emergency medicine journals and some great metabolic reviews. We're going to show that a high lactate isn't always sepsis. Sometimes it's a dying bowel or a simple vitamin deficiency.
Yeah. Or, and this is the one that really got me, it's a sign that your life-saving medication is actually working.
Exactly. So the mission today is to build a kind of mental checklist.
Yeah.
To move beyond that simple lactate equals no oxygen idea and get to the real cause.
Okay, let's do it. Let's start with the molecule itself. I think most of us learned that lactate is just waste, right? It's the stuff that makes your legs burn when you sprint.
That's the old dogma.
Huh.
The breathless sprinter model. But physiologically, that's really outdated. Lactate isn't metabolic trash. It's actually a premium fuel source.
Fuel.
A preferred fuel, even.
Yeah.
Your red blood cells, your brain, your muscles, they're constantly making lactate, even right now as you're sitting there.
So I have lactate in my blood right now.
You do.
Yeah.
A normal resting level is somewhere between 0.5 and 1.5. It's in a constant state of equilibrium.
Yeah.
Production and clearance.
Okay, so think of it like a bathtub.
Perfect analogy. The faucet is production and the drain is clearance.
And the drain is...
Mostly. The liver is the main cleanup crew, handles about 60% of it.
Yeah.
And the kidneys take care of another 30. It's part of what's called the Cori cycle.
Right, the Cori cycle. So it takes the lactate and just recycles it back into energy.
It recycles it back into glucose, a beautifully efficient system.
So if the level spikes to 8.0, my bathtub is overflowing. Either the faucet is on full blast, which is overproduction.
Or the drain is clogged, impaired clearance. And that distinction is the key. It's the foundation of the Cohen and Woods classification.
Okay, break that down.
It's the 2 big buckets you sort these patients into, type A and type B.
Type A is the one everyone thinks of.
Right. Type A is the classic danger, tissue hypoxia. The body's running out of oxygen. That's your shock, your cardiac arrest, a clotted off limb. The faucet is on because the engine is choking.
In type B?
Type B is the metabolic mimics. This is where you get high lactate without low oxygen. The perfusion is fine. It's something else. Drugs, toxins, maybe the liver is failing.
So type A is no oxygen. Type B is metabolic weirdness.
Got it. But let's get into a real case, the septic patient. This is probably the most common scenario. Is that type A or type B?
Well, that's what's so fascinating. Sepsis is a hybrid. It kind of breaks the rules.
I've always just assumed it was pure type A. The blood pressure drops, the organs aren't getting perfused, so lactate goes up.
And that's definitely part of it, especially in profound septic shock. But we see patients all the time with sky-high lactate who have perfectly normal blood pressure, normal oxygen levels.
But what's driving it then?
Adrenergic stress. In a severe infection, your body unleashes this tidal wave of adrenaline, catecholamines. And that slams the beta-2 receptors on your cells.
It's just flooring the gas pedal.
Exactly. It forces the cells into what's called aerobic glycolysis. They're burning through glucose so fast that the mitochondria, the little power plants inside the cell, they just can't keep up. So they start churning out lactate, not because they lack oxygen, but because they're revving way too high. Wow. Okay, that distinction is critical. Because if the lactate is high from adrenaline and not because of low blood volume,
then just dumping liters and liters of fluid into them might be the wrong move.
But the surviving sepsis guidelines, the Hour 1 bundle, they're pretty aggressive on fluids, aren't they?
Oh, they are. And you should be, initially. If lactate's over 4, the protocol is 30 milliliters per kilogram of fluid. You have to do that because you have to assume it's type A first. You treat the most immediate threat.
So you rule out the hypoperfusion first?
But, and this is the key insight, you have to watch the response. You're looking for lactate clearance. You want to see that number drop by, say, 10 to 20% every couple of hours.
And if it doesn't, if you've given the fluids and the lactate is just sitting there,
then you stop. You stop chasing the number with saline.
Yeah.
More fluid at that point just risks putting water in their lungs, causing pulmonary edema.
Yeah.
You have to pivot and think, okay, maybe the liver's failing and the drain is clogged. Or maybe this is just that massive stress response.
So fluids are not benign.
Fluids are a drug, and they have side effects. You have to know when to turn them off.
Okay, so that's the sepsis trap. Let's talk about the opposite end of the spectrum, the silent killer. We have a case study of a 75-year-old woman. This one is, well, it's scary.
This is the one that keeps ER docs up at night. She comes in, vague belly pain, some vomiting. Her history is significant for AFib, an irregular heartbeat.
And her vitals are a little soft, lowish blood pressure, fast heart rate. She's clearly in pain, but when you examine her...
The exam is a liar. Her belly is soft. It's tender all over, but she's not guarding. It's not rigid.
Pain out of proportion to exam.
That is the textbook phrase for acute mesenteric ischemia, dead gut. A blood clot from her heart has shot down and blocked off the blood supply to her intestines.
So her gut is literally starving for oxygen. That is classic type A. The lactate should be through the roof.
It should be. But here's the trap. In the early stages, it's often normal.
How is that even possible? You've got dying tissue just pumping out lactate.
You do, but think about the anatomy. Where does the blood from the gut drain to?
It goes through the portal vein directly to the liver.
And what's the liver?
The cleanup crew, the scrubber.
Right. So in that early phase, the liver is working just fine. It sees this flood of lactate coming from the dying bowel, and it eats it all up. It clears it before it can even get into the systemic circulation where we draw our blood sample from.
Wow. So the liver is literally hiding the evidence.
Until it can't keep up anymore.
Yeah.
By the time that lactate number finally spikes in the blood work, it usually means the bowel has completely infarcted. It's dead. The drain is finally overwhelmed, but you're too late.
So the takeaway for the clinician is, if you have an elderly patient with AFib and that severe belly pain, but their lactate is 1.5,
you do not trust it. You ignore it. You go straight to the CT angiogram. Clinical suspicion trumps the lab value every single time in this case. If you wait for the lactate to rise, you've lost.
Okay, let's flip the script one more time. We've talked about when a normal lactate is a lie. What about when a high lactate is, well, not a sign of impending doom?
This brings us to case study 3, the medication mimic. This is your pure type B2 lactic acidosis.
Severe asthma attack.
Exactly. Picture a 20-year-old. Can't breathe, status asthmaticus, or maybe severe anaphylaxis. And you give them everything.
Epinephrine, nebulized albuterol, all the beta agonists.
And clinically, they get better, the wheezing improves, they're moving air, they look pinker, so you feel good. But then you repeat the labs, and their lactate has shot up to 9.5.
And you panic. You think, oh no, did I miss something? Is she secretly septic? Is she crashing?
It's a natural reaction. But this is drug-induced.
Yeah.
Remember what we said about sepsis and the body's own adrenaline revving up glycolysis?
Yeah, the adrenergic stress.
Well, here you've just injected them with pure adrenaline. The epinephrine and albuterol directly stimulate those same beta-2 receptors. You are forcing the cells to make lactate. It is not a sign of worsening hypoxia.
So in this case, the high lactate is actually proof that the drug got where it needed to go.
Yes. In fact, there are some studies that suggest a rise in lactate in these patients actually correlates with better outcomes. It means the drug is working.
That takes some real nerve as a doctor to see a credible value get worse and think, good.
It does. But you have to treat the patient, not the number. If they are breathing better, talking to you, and their perfusion looks good, you don't start flooding them with fluids. You just watch, and as the meds wear off, the lactate will come down on its own.
Sepsis hybrid, hidden ischemia, medication mimic. This is so much more complex than I thought. Let's put it all together into that checklist you mentioned.
Right, so you're staring at the number. Here's how you process it. Step 1 is the look test. Immediate stabilization.
How does the patient look?
Are they in shock? Are they cold, clammy, hypotensive, confused? If they look like they are circling the drain, you assume it's type A until proven otherwise.
Don't overthink it. Fix the perfusion.
Put out the fire first.
Mm-hmm.
Fluids, pressors, find the source.
Okay, step 2. Let's say the patient looks okay. Blood pressure is holding up.
Now you do the hidden ischemia check. Is there a regional problem? We think about the 4 deadly compartments.
Run through them for us.
1 is mesenteric, the gut. 2 is a limb, a cold, pulseless leg. 3 is soft tissue, like a necrotizing fasciitis, a flesh-eating bacteria. And 4 is compartment syndrome, a crushed muscle.
All things that could be brewing locally without causing global shock right away.
Precisely. You have to go hunting for them.
Okay, what's step 3?
The toxin and drug screen. This is our type B2 bucket. We already talked about epinephrine and albuterol. The other big one to look for is metformin.
The diabetes medication, how does that cause it?
Metformin works by blocking the liver from making new sugar. It blocks gluconeogenesis. Part of that process involves clearing lactate.
So it clogs the drain?
It clogs the drain, usually it's fine. But if a patient on metformin gets acute kidney failure, the drug builds up in their system, the drain gets completely blocked, and lactate levels can skyrocket.
Got it. What's after drugs? Step 4.
The metabolic and clearance check. We ask, is the drain itself broken? Does the patient have liver failure? But there's a sneaky one here people miss all the time. Thiamine deficiency.
Vitamin B1.
Yep, thiamine is a critical cofactor. It's like the spark plug for an enzyme called pyruvate dehydrogenase. That enzyme is the gatekeeper that lets the products of glycolysis into the mitochondria to be burned for energy.
And if you don't have the spark plug?
The gate is locked, the fuel piles up, and pyruvate's only other option is to become lactate.
And who are we thinking about for this?
Classically, patients with alcoholism, but also anyone who is severely malnourished. If you have a patient with a high lactate that just won't clear and they have a history of malnutrition, just give them IV thiamine. It's cheap, it's safe, and it can be diagnostic.
Okay, finally, step 5, the gap check.
This is a rare one, but it's brilliant when you catch it. This is for the patient with short bowel syndrome. They come in confused, acidotic, but their lactate from the lab is normal.
But they're acidic, so something's wrong.
What's wrong is that our standard lab tests only measure one kind of lactate, L-lactate. That's the human kind. But bacteria in a surgically altered gut can ferment carbs into D-lactate.
And our machines can't see it.
It's invisible to the standard assay. You have to specifically order a D-lactate level. If you miss it, you'll never figure it out.
That's an incredible checklist. Shock, hidden ischemia, drugs, thiamine, and the invisible D-lactate. It really organizes the chaos.
And as you're working through it, you're always watching the trend. You get a baseline lactate, and you remeasure in 2 to 4 hours.
Looking for that 10 to 20% clearance.
And if you don't see it, if you've given fluids and the number isn't budging, that's your signal to stop and rethink everything. Is the diagnosis wrong? Did I miss that dead gut? Is the medication I'm giving?
One last quick practical point, venous versus arterial lactate. Do I need to put the patient through a painful arterial stick?
No, absolutely not. For screening and trending, a venous lactate is perfectly fine. It correlates very well.
The only caveat is, don't leave the tourniquet on too long.
Exactly. More than 2 minutes, and the muscles in the arm will start making their own lactate. You'll get a falsely high reading.
Before we sign off, I want to come back to something you mentioned in the pre-show notes, this idea of the lactate paradox.
Yeah. I mean, we spend this whole time talking about lactate as this dangerous thing we have to clear. But from an evolutionary standpoint, it's not a poison.
It's not the enemy.
It's a survival fuel. In the first moments of trauma or sepsis, the body intentionally ramps up lactate production because it's a fast, efficient energy source for the most important organs. The heart actually prefers to burn lactate during periods of stress.
So high lactate is the body trying to save itself.
In many cases, yes. It's a key part of the survival response, which makes you wonder, when we are so aggressively trying to fix the number, are we fighting the disease, or are we sometimes fighting the body's own elegant solution to a crisis?
That reframes the entire conversation. The check engine light is on, but maybe the engine is just revving high on purpose.
Exactly. Your job isn't to smash the light bulb. It's to figure out why it's on.
Look under the hood. A perfect way to end it. We'll have the checklist and key takeaways in the show notes for you.
And remember, treat the patient, not the number.
Stay curious, and we will see you on the next deep dive.